Traditionally, we separate myelofibrosis patients in the chronic phase patients that have between 0 and up to 10% of the blasts, and then 10 to 20% of blasts is accelerated phase. Above 20% is blastic phase or acute myeloid leukemia. A lot of effort is spent on understanding the transformation from chronic phase to a blastic phase to acute myeloid leukemia, because acute myeloid leukemia is very deadly. Average survival is about 6 to 8 months. And we put a lot of effort in treating and understanding how to benefit patients with acute myeloid leukemia that happens after myelofibrosis. But now we understand that patients actually transition through accelerated phase. People do not change overnight from chronic phase to blastic phase. They slowly increase the blasts and develop some other biological and clinical characteristics that define, or we are trying to define, what accelerated phase is, to catch patients while they're on the move to have acute myeloid leukemia, because acute myeloid leukemia is so deadly. So why not intervene earlier on, define what actually accelerated phase would be, not perhaps only on the blasts, which is between 10 and 20%, and find other characteristics like certain molecular findings, changes in karyotype, chromosomes, or for example, just simple platelets below 50 have been universally shown to be a detrimental prognostic factor and accelerated phase indicator. So if we can focus on this group of patients that are in transition from more chronic and stable condition to blastic phase, we can then implement therapies earlier on and save their life or direct them to the transplant, the only possibility to cure them sooner.